Presenting Dr. Jana Holroyd-Leduc. She's an academic geriatrician and head of the Department of Medicine at the University of Calgary. She is chair of the Brenda Strafford Foundation. Her research focuses on frailty and optimal aging strategies to improve the quality of life for older adults. But on a personal note, if someone asked me the top 5 women who are your role model, Jana would be one of them.
Hello. So just to correct, I'm the academic lead of the Centre on Aging. So I don't actually chair the Brenda Strafford Foundation, but the Brenda Strafford has funded the University of Calgary Centre on Aging. So just wanted to say that I don't have any relevant conflicts of interest. I joke as a geriatrician, no one ever gives me money because I tend to de-prescribe and promote healthy lifestyle, and so nobody really gives me money to do that. So, and then I'm going to try to use person-first and inclusive language, but if you see ways I could improve, please let me know. And land and knowledge has been done, but I just do want to remind everyone of our accountability to Indigenous people, including the calls to action and Truth and Reconciliation Commission that includes health-related components. So someone mentioned earlier about the aging population, and yes, the Canadian population is aging, like the world's population, and we're aging quite rapidly. Although I do want to sort of counterbalance what someone had said, it's a gray tsunami. I actually don't like the word tsunami. It suggests that having a lot of older people in our society is a bad thing, and I don't think it actually is. I think what we actually have to do is address ageism and actually start appreciating that older adults have a lot to give to society. And so, you know, just showing this graph though, in about 2015, so that bottom little gray triangle, those are the people over 65, and then the round black circles are the ones under 15. So in about 2015, those two groups crossed. And so now our population in Canada, there's more people over 65 than under 15, which means we do need to start thinking differently and prioritizing differently. Maybe we do not need to promote funding of research and funding of other things that are relevant to an older population, and maybe a little bit less funding, say, the children hospital, for example. Unfortunately, in our society, as we age, we do tend to experience chronic medical diseases. So if you look at this diagram here, it shows by age category that the prevalence of the most common chronic conditions, so they looked at 11 different things, starts to go up. And by the time you're over 65, about almost 80% of people will have at least one of these. And as we continue to age, that continues to increase, which is not surprising. As we age, we're going to we live longer, we've been exposed to a lot more environment, our genes start to play a role, you know, our lifestyle starts to play a role, and we are going to tend to see more chronic diseases. It's just a natural part of aging. Medicine has been great. Modern medicine has helped people stay alive. People aren't dying as young. Our life expectancy is higher than ever. But if you actually think about it, we haven't cured a lot. So occasionally we've cured some cancers, but a lot of other diseases, what we've done is we've changed acute diseases into chronic diseases, which means people will live longer, but they will also live longer with the consequences of these chronic diseases, so the morbidity and the disability associated, which also means as we age, we see more frailty, which is what I'm going to talk about as a geriatrician. So what is frailty? And I think somebody may have already talked a bit about this earlier, but it's this state of increased vulnerability to adverse health outcomes compared to others of the same age. So if we look at 2 80-year-olds, what's their risk of something happening to them? It's a result from reduced physiologic reserve. It also reduces our ability to cope with normal or minor stresses. So for example, you know, a urinary tract infection in someone that's older and frailer may end up with them having to go to hospital and being quite ill, versus in a younger person that didn't have chronic diseases and wasn't living with frailty, you know, they could take a couple days of antibiotics and the issue would be gone. So it does impact our ability to deal with health issues. And it's also associated with increased risk of physical, cognitive, and functional decline. And often we think about frailty as having a physical component, a cognitive component, and also a social component. There is a degree of social frailty in terms of, we know that populations that live vulnerably housed tend to experience frailty at a younger, starting at a younger age. And I'm just showing you that frailty should be thought of on a continuum from being robust to end of life. And people can be at various stages and they can move along this frailty axis. And the other thing to note about frailty, as we get older, the prevalence does tend to go up, which I'm going to show you, and the reversibility of it tends to go down. So harder to go from moderate frailty back to mild frailty as we get older. So how do we determine frailty? There's two main models that have been used in the literature. One is Linda Fried's model of the frailty phenotype, which comes out of the US, and she's based it on 5 variables. So you look at unintended weight loss, you look at exhaustion, you look at someone's gait speed, their grip strength, and then their energy or how sedentary they are. And if you have none of those criteria, you're robust, and then if you have 3 to 5, you're frail. And so it's a performance-based. There's various ways to measure these and measure your performance in them. So really validated, used a lot in literature in terms of research, not that applicable in day-to-day clinical practice. The other method is a Canadian method, so this is Ken Rockwood and also others, including Dave Hogan, who's a geriatrician here in Calgary, was involved in this. It's called a frailty index. And what they do is you look at any number of deficits and you see how many does a person have. And it just turns into this ratio, so it's continuous from 0 to 1. And if you have at least a quarter of those things that are looked at, then if you want to just define it as frail or not, you'd be defined as frail. Although it's on a continuum, so your level of frailty, the closer you are to 0, the more robust you are, the closer you are to 1 is the frailer and more end of life. And typically in the index, nobody scores above about a 0.7 because a score higher than that is probably not compatible with life. You have too many deficits to actually be compatible with life. So this does require a comprehensive geriatric assessment or a comprehensive look at databases. But it's really helpful in sort of determining frailty. So why do we want to determine frailty? Well, if we look at frailty in Canada, frailty does increase with age, but they're not synonymous. So not everybody necessarily follows the same frailty trajectory. But we also know that our decline in health status is driven more by frailty than it is by age. So if we, in an ageist society, just say anybody that's over 65, 75, 80 shouldn't get access to healthcare, we're going to deprive a whole bunch of people that are actually living quite robust and not living with frailty to health benefit, things that they could benefit from. The other thing about frailty is it is associated with healthcare utilization. So if you look at the diagram, after the age of 65, about a quarter of the population is living with frailty, which also in the inverse means 75% of the population over 65 is not living with frailty. And when we look at those over 85, it's about 50-50. So once again, there's a huge portion older population that's not living with frailty. So we've talked a lot, there's a lot of talk about how do we, longevity, successful aging, or I would say how do we sort of prevent frailty. And there is some really interesting data out there. So we know that practicing healthy behaviors has lots of benefits for chronic diseases. And there's also evidence that it actually, if you want to say, I don't like the word necessarily successful aging because it infers that it's on you to successfully age, when actually I think it's more complex than that. But if you want to live without diseases and without frailty, there are some things that we can all do. So this study was a cohort study that looked at over 5,000 people between 42 and 63, followed them for almost 2 decades, and showed if you don't smoke, you minimize your alcohol consumption, you participate in regular physical activity, and it wasn't a lot, it just had to be a few hours a week, and you eat your fruits and vegetables, which what we were all told as children probably to eat our fruits and vegetables. Yes, you need to eat your fruits and vegetables. And there's a linear relationship. The more you did of those things, the more likely you were to successfully age. The other thing is we recently did a systematic review and practice guideline around what can you do for help older adults that are living with frailty and pre-frailty. And what we found was that physical activity was actually a very powerful intervention in slowing the progression of frailty and reducing its severity. And it was a combination of aerobic activity, resistance training, balance, and flexibility. So you don't actually have to take a medication, you don't have to do any fancy testing, you don't need a fancy, prescribed diet, you just have to move. That's the most powerful thing we can do is move. Move and do activity, and it doesn't have to be at a fancy gym, just move. So back to what John Brown said, we need to have communities where we can move, and we are walking and we're doing, and we're not driving, we're not, we're actually staying active every day. That's the most important, powerful thing we can do. We did find some evidence around nutrition, but it's very, the evidence was relatively weak. Need more research on it. Some evidence that maybe a high protein fortified food is probably of value when you're living with frailty. So lots of talk about the microbiome, so I wanted to sort of look what's out there about frailty in the microbiome. Very early evidence. This is one study that you can look at. It does suggest that there is an association between sort of lower microbiota diversity and frailty, and that there's certain, depending on what is in your microbiome, some components may be associated with, if you have more of that, you might be more likely to be frail. If you have less of certain types in your microbiome, you might also be more associated with frailty. But more unanswered questions than answered, I would say, at this point. We don't really understand the relationship between the microbiome, inflammation, and frailty. We don't really understand the microbiome and its relationship to chronic disease and frailty. And also there's early evidence, there's some researchers, so at the University of Calgary, here locally, there's an international microbiome, a lot of research going on. And there's some early research that one of our gastroenterologists, Dr. Meiji Raman, has done, where she's actually showing that doing yoga actually changes your microbiome. So it's bidirectional. Which is really interesting. It's not just about what we eat changing our microbiome and changing our health, but actually it's more complex than that. So we need to be funding and doing more research. We're not yet prime time ready to be really marketing this, I think, to the individual. We need to understand it better. And the last thing I wanted to talk about, this concept came up of geroscience. And I think that's also where we really need to be moving. It's interdisciplinary research that's focused on understanding genetic, molecular, cellular mechanisms of aging, and looking at, they are a major risk factor in common chronic diseases. So this looking at our aging biology and diseases and understanding them better. And so that's an area really of evolving. And there is a new Canadian transdisciplinary geroscience group that's actually moving forward on this. A lot of research right across academic institutions in Canada. And so to wrap it up, I think when we think about precision health and frailty risk, it's this combination of our environment, our microbiome, and our aging biology, but we don't fully understand, what interventions are actually going to work. And so we need more research. We need to understand it better in terms of, how do you optimize decrease your risk of frailty and optimize your health as you age. And ultimately, I also want to suggest what we want to really do is we don't just want to live longer. What we want to do is compress our disability and mortality curves with our lifespan. So basically what that means is you want to live as healthy and independent as possible, right up to ideally the day you die. So you live to be 95, 100, and you're totally independent and optimal, and you're living well. Maybe you have some chronic diseases, but you're living well, and then you pass away. Unfortunately, only about 1% of the population dies suddenly that way, and that hasn't had a lot of health issues. Most people are going to live with some chronic disease and some morbidity and disability. So we need to be working to actually try to compress that, so people can live with chronic diseases, but not with the associated morbidity and disability. And that is my presentation. Thank you.